Hello, everybody. Welcome to the PrecisCa Hematologic Malignancies Tumor Board. Very happy to have you here. Very excited to go through some of these really interesting cases. The cases that we are going to focus on today are all patients with various forms of lymphomas. We have an outstanding panel with us here today to go over these cases. I'm very excited to be amongst them. I'm going to first introduce myself. I'm Dan Pollier from the University of Colorado, and I'd like each of my colleagues to introduce themselves. Dr. Fromm, please.
Hi, my name is Tyler Fromm. I'm an assistant professor of radiology with appointments in abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri. I specialize in oncologic imaging with a focus on MRI and PET examinations.
Larry Keston. I am a radiation oncologist in Michigan, in the Detroit area. I work for Michigan Healthcare Professionals and Genesis Care USA. I'm the medical director of the Michigan region.
Hi, I'm Jeremy Abramson. I am a medical oncologist specializing in lymphoma. I direct the lymphoma program at the Massachusetts General Hospital in Boston, and am associate professor of medicine at Harvard Medical School.
John Pagel. I am the chief of hematologic malignancies and the director of the stem cell and cellular therapy program at the Swedish Cancer Institute in Seattle, Washington.
So this is a 45-year-old Caucasian male with stage 4 classical Hodgkin lymphoma who has now recurred. The recurrence occurred after 6 cycles of curative-intent multi-agent chemotherapy, now with a retroperitoneal mass and extensive bony disease. So we're going to talk about second-line strategies here, but let's talk a little bit more about this particular case. So this patient comes in with back pain and night sweats. Again, performance status is 0. History of hypertension in that Hodgkin lymphoma that we discussed. He is a smoker and has no family history of hematologic malignancies. So in 2019 into early 2020, the patient had ABVD for 6 cycles. We don't know from this, what the original staging or risk categorization was. But the patient did have an end of treatment PET-CT with a complete metabolic response in April of 2020. Now the PET-CT was repeated, and Dr. Keston, maybe you can take us through this relapsed PET-CT.
Yeah, I can take you through that. So in the center here, we have another maximum intensity projection image, just kind of showing the distribution of activity throughout the image portions of the body. And here we see a case where there is extensive involvement of multiple lymph node chains above and below the diaphragm, including a large conglomerate of lymph nodes in the abdomen and pelvis and the retroperitoneum that we see on the left-sided transaxial slice that's sort of encasing the inferior vena cava and aorta, as well as the iliac vessels there. We can also see on the MIP in the center that we have some sort of retention of the radiotracer to a greater extent than expected in the renal collecting systems bilaterally. And the ureters are kind of coursing through that conglomerate there in the retroperitoneum. So presumably there's some degree of mass effect on them that's kind of, preventing the kidneys from, emptying the way that they normally would. We also have extensive osseous involvement. This is one of those cases where we can look at and just say clearly that there's involvement of the bone marrow throughout the axial and proximal appendicular skeleton, as well as several lesions, such as on the image on the left, where some of the osseous disease may have some extra osseous extent into sort of the left neuroforamen on that side, and then on the right-sided transaxial image, some activity within the spinal canal there. So yes, very extensive disease on this study involving multiple lymph node chains above and below the diaphragm, as well as multiple osseous lesions. And we're also told that the patient had some right pleural disease, which I think is kind of that area of confluent activity that we're seeing kind of projecting over the inferior right hemithorax.
Great. Thank you. So, Dr. Abramson, can you give us a sense of a patient with this original presentation who achieves a complete metabolic response? When patients do relapse, what's the range of the time course of the relapse that you see? I mean, I know there are extremes, but what's sort of the average time to relapse?
Well, it's certainly highly variable. Patients who relapse typically relapse early, usually within the first couple of years. The time to relapse also impacts their prognosis to some degree. Patients who relapse the earliest, meaning if they're primary refractory and never achieve a complete remission or relapse within less than 1 year, have more chemotherapy resistant disease and have a lower overall cure rate than patients who relapse in their second, third, or fourth year. So while the majority of relapses do occur within a couple of years, there is a low rate of ongoing relapse, even at 3 years, 4 years, very few after 5 years, but we've all seen the occasional case that's occurring much later. This patient is progressing a year later, which is fair, a fairly routine time to recur. It's occurring relatively quickly after their initial therapy. And of course, this patient presented with high-risk disease. This patient had stage 4 disease, we're told, at the time of presentation. And so this patient would have been at some increased risk for recurrence, although having achieved a PET negative complete remission, I would have been optimistic that they had been cured, which unfortunately they've relapsed. However, most notably, Hodgkin lymphoma is a treatable disease with a goal of cure, even in the relapse refractory setting.
And Dr. Pagel, how important would it be for you to repeat a biopsy in the setting of this patient's history and this the clinical symptoms and now this imaging?
Yeah, it's a super important question. I had even alluded to that earlier in the past case about getting biopsies to make sure that you don't have false positives. This is not a case of a false positive. This is widespread recurrence, almost assuredly. I would never fault someone for getting a biopsy, and I would encourage that obviously here as well. I would do it just to make sure that we didn't miss the original diagnosis, to be even more honest, in that this is not behaving like you would normally want it to, but it can happen. If you weren't able to biopsy something here for some reason, it just something wasn't accessible for some reason, then I think it would be okay to assume that this is relapsed Hodgkin lymphoma. But there's many places to biopsy here, and I'm always a proponent and I think it's highly important to get biopsies in this type of setting anytime that you can. And that's, again, just to be clear, because there can be false positives. Usually false positives are one type of area that's on a persistent scan at the completion of therapy, not a year later. And you want to, here in this case, you want to make sure that it's not some other type of disease.
Great. Thank you. So back to the history, this patient did have a repeat needle biopsy of the left supraclavicular lymph node. It was a CD30 positive recurrent classical Hodgkin lymphoma. Normal bone marrow function, renal function, liver function, LDH was elevated, TTE and TFTs all normal. So, Dr. Abramson, how would you approach this patient as the first line salvage or second line treatment setting?
Yeah, the management of relapsed Hodgkin lymphoma has certainly been evolving with the development of the novel agents, Brentuximab, vedotin, and the immune checkpoint inhibitors. A young patient like this, I would still approach with standard second-line alkylating-based chemotherapy, which has been our standard for quite some time. In this patient, I would probably use ICE, ifosfamide, carboplatin, and etoposide, repeating a scan after a couple of cycles. And if the patient is responding well with chemotherapy-sensitive disease, plan for a third cycle of ICE, collect their stem cells through the peripheral blood through stem cell stimulation, and then perform high-dose chemotherapy with an autologous stem cell transplant. This patient had a high-risk recurrence. High risk at recurrence is defined by an early relapse, so primary refractory or relapse within a year, extranodal disease or B symptoms. This patient clearly has extranodal disease with their skeletal involvement, and it was a fairly quick relapse as well. And in that population, we actually have a randomized trial that takes patients who go to the transplant and then randomizes them to receive Brentuximab vedotin as a maintenance therapy administered once every 3 weeks for up to 1 year versus placebo. And what that clinical trial called the Athera trial taught us is that for patients who have chemotherapy sensitive disease to ICE, go to high dose chemotherapy and stem cell transplant, and then receive Brentuximab vedotin maintenance, they had a significant improvement in their progression-free survival, meaning more of them remain in remission than patients who receive placebo. So for a high-risk patient like this today, I would do ICE, followed by BEAM, an autologous transplant, followed by Brentuximab vedotin maintenance. I think a big question going forward, and a question being asked by ongoing trials, is whether we should use the targeted therapies in combination in lieu of potentially chemotherapy, say Brentuximab vedotin and an immune checkpoint inhibitor. Right now, I think those data are still really in smaller numbers of patients and still immature. And so I would favor a more standard transplant approach followed by Brentuximab vedotin maintenance and reserve immune checkpoint inhibitors as a strategy at their next relapse if that were ever necessary.
Thank you. And Dr. Pagel, we were told that this patient expresses CD30, bringing up the at least possibility of Brentuximab, although as we just heard, perhaps that's not the preferred first-line salvage therapy. How frequent is CD30 expression in Hodgkin lymphoma in general, and particularly at relapse?
It's an important point, clearly, because CD30 is the target for Brentuximab, the antibody drug conjugate that we've been discussing here. And you need to, of course, have that target, and you want to make sure that it's present on the Hodgkin lymphoma cells, not just at the time of diagnosis, but at the time of relapse as well. It's almost always present. In fact, it's a classic hallmark of the immunophenotype of Hodgkin lymphoma to be CD30 positive. One of the questions that arises around that issue is the degree of CD30 positive. And sometimes people will wonder if patients will respond as well to the therapy if they've got lower expression, I put lower in quotes perhaps, compared to people that have a high antigen density level of CD30 on the Hodgkin lymphoma cells. It turns out that the data suggests to us that the density of CD30 probably doesn't make a significant difference in the ability of a patient to have a response to the Brentuximab vedotin. So CD30 is commonly expressed on Hodgkin lymphoma. You'll see it on any routine pathology report that's describing the immunophenotype of Hodgkin lymphoma, and do recognize that that's important because it's the target with Brentuximab. So in this patient, I might have even considered using Brentuximab in the front line. This patient did have high-risk disease. Dr. Abramson noted that. So one of the other approaches that we could have done, now this patient got 6 cycles of ABVD, which is certainly valuable and appropriate. We talked about the Rathel trial where that advanced stage data is supported in that approach. There was also a large intergroup study run through the Southwest Oncology Group in the United States for patients under the age of 60 with advanced stage disease to get 6 cycles of ABVD. So the data is certainly supportive of that, but it was also alluded to by Dr. Abramson early on in our presentations, the regimen of Brentuximab vedotin with ABD from the Echelon 1 trial. And this might have been a patient I would have used it where that regimen is approved for advanced stage 3-4 patients like this at the front line. And the reason I might have considered that regimen in the front line is that we now have 5-year follow-up data from that Echelon 1 trial. It was just presented at the American Society of Hematology meeting in December of 2020. But what it clearly shows is that there was a 5-year true progression-free survival advantage for those who got AAVD, meaning Adcetris or Brentuximab vedotin with AVD, versus those who got ABVD. I'll just say another word or two. Of course, I know I'm maybe going a little too long to answer your question. But let me also say that that really does then change how we would treat patients in the relapse setting if they had gotten Brentuximab up front. So remember, one of the issues around Brentuximab that's been discussed as well is peripheral neuropathy, and it's cumulative, and it's something you have to keep in mind, especially if you're going to use Brentuximab in the relapse setting when they've had it in the front line or even after a transplant, as Dr. Abramson's alluded to. You know, lastly, I would say I would approach this patient in a very, very similar way to Dr. Abramson. This patient likely is a transplant candidate. I'm going to try to get stem cells collected and stored. I do commonly use the ICE regimen as well. But I will also confess that I'm not sure what the right salvage regimen is, even if I'm going to take patients to transplant. There's a variety that are looking extremely promising in patients that are super high risk like this patient. There's certainly regimens now of using Brentuximab with what we call augmented ICE. I like that regimen. It was been pioneered a little bit, has been pioneered as well from Memorial Sloan Kettering Cancer Center, where you give Brentuximab just as a single agent. And if patients are getting a negative PET scan after a couple of cycles, then they don't need chemotherapy. And there's regimens of using Brentuximab with bendamustine. And there's even regimens of using Brentuximab and or nivolumab and these novel agents without chemo as now bridges to transplant. And lastly, there's a very exciting regimen that's just been reported using nivolumab with what we call GVD, gemcitabine, vinorelbine, and liposomal doxorubicin, small numbers, but in very difficult high-risk salvage patients with response rates of around 100% that could get them to a transplant as well. It's a complicated issue. This is a complicated patient, and I think that the strategy of getting this patient to a transplant is the most important. And it probably doesn't matter how you get them there, but get them there, and then hopefully you have a chance for that second bite of the apple to cure them.
Great, thank you for that detail. That's really helpful and very interesting. Definitely agree. It's a challenging case.